Welcome everyone to the She Can Fix It podcast. I hope you all are staying safe during this time. This month's episode consists of a great interview with Dr. Serena Hu. Dr. Serena Hu is chair of the Division of Spine Surgery, as well as a professor within the Department of Orthopedic Surgery at Stanford University School of Medicine. She is also the second president-elect of the American Orthopedic Association. I wanted to interview Dr. Hu not only to understand her passion for spine surgery, but also understand how she became such a prolific researcher. I had a great time speaking with Dr. Hu, and I'm very excited to share our conversation. I hope you enjoy this episode of the She Can Fix It podcast with Dr. Serena Hu. Dr. Serena Hu, thank you so much for joining me on the She Can Fix It podcast. I really appreciate you taking the time to speak with me, and I'm so excited to finally meet you and speak with you. So I guess my first question for you is if you can, in your own words, describe your background, where you went to medical school, residency, fellowship, as well as your post-fellowship years.
Okay, sure. Well, I'll start. I went to college at Cornell. And that's relevant because there were a lot of Canadian hockey players, which is how I went to McGill in Montreal for medical school, because they talked about Montreal and McGill. And then I did my residency at the Hospital for Special Surgery in New York. And then I went from there to a spine and scoliosis fellowship at Rancho Los Amigos in LA. And then my first job out of fellowship was actually in Minnesota at the Twin City Scoliosis Center. And then my mentor there took a job as chairman at UCSF, and then I followed him there to UCSF. And I spent 22 years at UCSF, and then about 6.5 years ago, I moved from UCSF to Stanford.
So you've gone all over the country.
Yes, I have.
Are there certain things from each of the places that you found to be different in terms of the way that they did things? And did you try to bring your own style to each new place that you went to? Or did you find yourself kind of conforming to kind of the style of each new location that you went to?
Well, in your training years, you really don't have a lot of options from the standpoint of, imposing your style, as I'm sure you've learned. You got to do what you got to do. But I think, you're learning, so you want to be learning from the people that you're training with. Minnesota was my first job. It was a very well-established scoliosis center, so it was very easy for me to just kind of, it's my first job out of fellowship. It was easy for me to kind of just say, okay, well, this is how they've been doing this at this famous place. I should learn how they do it. And then, but then when we went to San Francisco, it was essentially building a department. So it went from a really, really small, very community-based department to a very, a really well-known, very prominent department. And so in some ways, my chairman, who was my mentor, kind of grew it in the way he wanted to from an educational academic standpoint. And I was there sort of, helping him do that. So I was chief of spine by the time I left UCSF, and then I made a lateral move to Stanford. But it's one thing to come in as a chief of spine. It's a different thing to kind of grow up and become one in the place that your mentor's been. So it's kind of like being a grown-up and never having been the kid there.
I'd like to transition to your subspecialty of spine surgery. Spine surgery is a very unique field within orthopedic surgery, so I was hoping you can talk to us about how you initially became passionate about spine surgery.
Well, actually, so I started off really liking scoliosis surgery, pediatric scoliosis surgery, because I really liked working with kids. I really liked, the fact that you could take a spine that was curved and make it straighter with the instrumentation and, change that deformity. I liked the patient population. And I ended up deciding to do spine as opposed to pediatric orthopedics because that's the part of the pediatric orthopedics that I like the most. And I ended up liking the adults too, as opposed to just the pediatric stuff. And it was also kind of a field that I liked but didn't have a lot of exposure to. So when I trained, there were more people that did general orthopedics, and I thought I would do sports medicine, total joints, and spine. And when I started, I actually did do that for a few years. But nowadays, obviously, you have to kind of, especially in a university or a big city, you have to have, subspecialized. So I started out training in spine because it was the thing I wanted to do that I wasn't as comfortable doing as I was, say, total joints or sports.
Wow, that's amazing. And I think what's for me what's so interesting is like right now as a PGY2, I find spine to be a very like almost a scary thing in the sense that you're working so closely with the spinal cord and the nerve roots. And so what are your words of wisdom to those surgeons in training who look at spine surgery with trepidation and fear?
Well, it's really about training and control. So, you obviously you don't start out by doing a big operation. You start out by just learning how to expose the spine. And part of that and being safe is understanding the anatomy. I mean, obviously, everywhere in just any surgical field, you have to know the anatomy. But obviously, in the spine, and when there's parts of the anatomy that are so potentially dangerous versus safe areas, you really have to understand the anatomy and the three-dimensional anatomy more deeply than, not to trivialize the tibia, but the tibia is the tibia. You can find it, you can feel it. You know where the nerves are, but if the tibia is right under the skin, and so it's a lot easier to kind of know where you are, and the anatomy is more straightforward. It's more triangular. You kind of know where the nerves are going to be. The spine, once you know it, it's easier to know where the anatomy is. But until it's much more like where the nerves travel within, say, a vertebral segment. You have to kind of know where the thecal sac is versus the nerve roots versus the aorta. So understanding that three-dimensional anatomy is really the way to do it safely, and that just takes study and practice.
Another myth about spine surgery is that the stakes are high in every case. Would you agree with this assessment that there is more pressure, so to speak, in spine surgery? And if so, how have you dealt with this pressure?
I think that's true, although if you do a knee or a hip surgery wrong and you end up with losing a limb, that's just as high a stake as if you accidentally paralyze somebody. So certainly you could say that there are definitely parallels among all the different subspecialties. I guess it's probably, I don't want to say more common, but I guess because of the nature of what we do, when you have somebody who has a spine trauma or a tumor, you're more often dealing with a situation where paralysis is closer or more at risk than, say, a routine hip replacement. Um, but certainly revision hip replacements, or, complex, those kind of things. I mean, they're certainly high risk. That being said, I mean, yes, I think there is probably potentially more stress or more pressure in spine surgery because you're always in that area. Dinging the sciatic nerve is not good, but dinging the spinal cord is really bad. So I think you deal with it, I think, by, graduated responsibility, learning the anatomy, and knowing when to stop and not go too far. And, it's not always about the home run. It's a lot of times it's about the safest choice.
Very cool. I really do appreciate your honesty with that because I think it's something that there are future spine surgeons in medical school and in residency. So I think just letting folks know that spine surgery is something that is tangible for them and something that they can do, I think, is really important. I do want to transition and talk about your research. You are a prolific researcher, and I just wanted to first talk about when you first became interested in spine research.
Well, I think a lot of it just, I actually, my residency, as I kind of alluded to, at the time that I was there wasn't a lot of spine research being done. I think spine is I don't want to say it's a new field, but the complexity of it and the research done in it is not as well established as some of the areas within like knees or hips or trauma, for example. And so I really wasn't exposed to spine research until I was a fellow, which kind of makes sense. And then I was at Rancho Los Amigos, and that had a lot of spinal cord injury patients. And there were a couple of people that I worked with who were very, very into research. And so having a chance to work with people that had great ideas, knew how to write a paper and get the paper published was really key. Because just writing a paper it's not the same thing as like writing a short story. Obviously, it's not the same thing as writing a case report. It looks like from the way you're nodding, like knowing how to go about writing the paper and putting together things. It's not necessarily intuitive. So having kind of the right mentors to help me learn how to do that really was key. And I've always liked writing. although obviously writing scientific articles isn't the same thing as writing a short story, um, it still was something that I enjoyed doing and editing and kind of getting from trying to distill what I was trying to say into a way that the reader could understand and, could argue for that having value to be published, for example.
Very cool. How has your research changed and evolved over the years?
Well, I started with fairly simple questions, like, a few biomechanics studies, like testing, is this strong enough to do this? Or, like one of the early studies was putting augmenting a screw in the spine with a special kind of of hydroxyapatite, and was that stronger, and could it be used? And it's a very simple biomechanics study. I've done a lot of kind of clinical research, and that's just sort of when you're seeing patients. How common is this problem that I'm seeing, or could I do it better? And if I review my last 20 or 50 cases, is there something that works better in this particular situation, or can I compare it to how somebody else does it or how it's done in the past? So a lot of it's just kind of questions that arise as you're working and seeing the patients. Um, and so that's kind of evolved. I think there's been a big uptick in using databases to do research, which we've been able to do. Obviously, it doesn't take the place of a randomized control study, but it's getting harder and harder to do those. But you also have to, understand the limits of database studies too. So it's balancing that and kind of having clinical research, which is immediately relevant and is a lot more granular and a lot more real data, and administrative data obviously abstracted and from really large databases. So it's very powerful, but you have to be careful on what, the expression garbage in, garbage out. So it's only as good as the data that gets put in. So you have to be careful about the conclusions you make. But it is getting easier to do that. And so that's been, something that's evolved over the years. But I still do a lot of clinical research, just because obviously with a busy clinical practice, you're always asking questions like, well, what about this and what about that, and how are these patients doing well if I did this, or are they not? And just trying to kind of analyze and kind of be critical of what you're doing to make sure that we're actually helping patients.
That's amazing. If you wouldn't mind, can you share some of your current research interests, and are there any projects that you're very excited to that you just finished up or that you're just currently starting?
Sure. So we have a lot of interest in resource utilization, and so patients who everything. Well, there's like two different projects that are related. One project is looking at resource utilization before people have a spine surgery, and we've noticed that some people are very high utilizers, and not surprisingly, in the months before they need a spine surgery, they're taking more medication, they're using more physical therapy, they're going to the doctor more, and so it kind of makes sense that that kind of escalates. But it's interesting watching the patterns of how that kind of decreases over after surgery. And some people basically continue to be really high utilizers, and some you fix their problem and they go back to like using hardly any. So we've been trying to look at that pattern. That's a database, administrative database study. And then we're also looking at use of opioids in a similar sort of pattern. And another study we're doing is actually a prospective study looking at the use of opioids, and whether or not weaning that opioid use before surgery can help with outcomes for those patients.
Ah, that's fantastic. What is your advice for surgeons in training when they are pursuing research in residency and beyond?
I think start with having a good mentor. Somebody. It doesn't have to. It doesn't matter what your subspecialty is or what what the subspecialty you might be interested in. Find somebody who is a successful researcher that you would like to work with. Because the way you do research, it's you can ask different questions, but the doing quality research is kind of the same across the different subspecialties. Okay, and so if you learn how to from somebody who's learned how to get things published, learned how to ask good clinical questions, learned how to do appropriate statistical analysis and respond to reviewers, designs, that's sets a great foundation from the standpoint of having successful research. And if you don't set up a good hypothesis and good study design, the likelihood of being able to actually publish a paper is less. So you spend a lot of time doing the project, but if you can't get it finished, in a way that your reviewers want see as valid, then you've spent a lot of energy doing, and you end up with a lesser journal or not answering questions that you really want to answer. Um, so, um, so spending time learning about how to do good research is really important. And then it's about posing the questions, and the more experienced you are, obviously the better the questions are. But also looking at the literature, because it's amazing how many things have already been done. And some of it can be, the way we did research 20 years ago isn't as good as a lot of the research we do now, but some of it was better too. So, knowing the literature before starting on a project is really key. And so those are probably the two most important things, I would say.
Great. Thank you so much for sharing that. I think it's just very helpful for us residents just to kind of think about, because I think we just place so much of an emphasis on getting as many publications as we can on our CVs and such. And so I think it's just great to know that it's, the quality of what we do actually does matter.
It does. It absolutely does.
I do want to take a turn and talk about your leadership roles. You have had active roles in numerous societies, including the American Orthopedic Association, the Scoliosis Research Society, and the International Society of the Study of the Lumbar Spine. And my question to you is, why was it important for you to hold all of these leadership positions in these various societies?
That's a really good question, because it didn't start out as me it being important, but it was starting out with me being asked to do things. And I think what happens is, you don't learn to say no until it's too late, and so you end up saying yes to everything that sounds interesting. And then you discover that actually it's kind of fun to do these things. It's good to have a say in, like, the program of a certain society or the direction of how things go. And then once you do it a little bit, they start saying, "Oh, are you interested in leadership?" And you're like, "Oh, that sounds like fun," whatever. And then you start, and leadership, nowadays is much more kind of recognized as something that's legitimate, as opposed to, and has certain skill sets, as opposed to just being a really good surgeon and then you become the leader of whatever group. Like in the olden days, the best surgeon became the chairman, but the best surgeon may not be the best chairman, right? They might be really good at surgery, but they might not be very good at administration. And the same thing happens within societies. So I think learning, what you're good at, and learning that hopefully I'm still a good surgeon, but learning that I could do administrative work and lead things. And a lot of that is just learning how to communicate properly and effectively. And I found that I was, I think, pretty good at communicating. And so hopefully that's why I've been selected to do those things. And it is important to do it, I think, because you want to have people that are good and care about the societies and care about the departments. And it's much better for people who are doing it for the good of the group, rather than doing it for just their own egos. And so, that's I think that's one of the reasons that I've ended up being involved in a lot of leadership.
Do you think that there is a underrepresentation of women in leadership positions? If so, why do you think this exists?
Well, the first problem is, obviously, there's very few women in orthopedics, right? I mean, I don't know what we're up to. Are we up to 10 or 12% or something now? It was like 6 or 3 when I was going through. So it's kind of like chairman of the board of, Fortune 500 companies. You've got to feed the pipeline, and so you've got to get more women into orthopedics. But it's also, just like in the Fortune 500, people appoint people that look like themselves and think like themselves. So it's part of, like, breaking that glass ceiling. And I think, number one, so we, with the American Academy of Orthopedic Surgeons, you probably know, is the largest orthopedic group in the country, and we now have a woman president. The first woman president we have, Christy Weber. Okay, and then the American Orthopedic Association is kind of the academic orthopedic association, and it's actually the oldest orthopedic association. And I'll be president of the AOA in 2 years, and I'll be the first woman president of the AOA.
Oh my God, congratulations.
Well, thank you. I wasn't doing it for kudos, but more to say, like, but once you kind of break the barrier, it's like, okay, now it's happened. Now, why hasn't this happened sooner? And it kind of opens the door, And I think there are definitely, I mean, I can name, 2 or 3 women in leadership positions in the AOA that could very well, be the second, third, and fourth woman. And it shouldn't be a big deal. It should be just part of the best person getting the job, and that's part of breaking those barriers. And the good news is that I think I think most orthopedic surgeons in my age range understand that. I mean, there's still some old guys who think that women shouldn't be orthopedic surgeons, but they're kind of retired by now. So
That's no, that's it's true. I think that there's I think that there's room to grow, and I think that there's a lot of great women coming through the ranks. And so I guess speaking of those women, what advice do you have for those who are interested in committing to leadership positions in various orthopedic societies?
well, you start at the bottom like everybody else does. You volunteer for committees, and you do a good job in the committees, and then you hopefully get nominated to run the committee chair. Or I mean, different societies have different structures from the standpoint of committee chair. Like the SRS has a council chair that kind of has several committees within each council. So being a council chair is important in the SRS, but the AOA doesn't, for example. So you have to kind of understand the structure of any group that you belong to, whether it be the societies or your department, and understand how one gets chosen for those, volunteer when it's appropriate, and talk to people about your interest. A lot of times people like don't think of certain people because they're more quiet. Like an introvert may not get offered certain leadership positions, but introverts are just as good, if not better, leaders. But they might not be out there screaming at people. So if it takes volunteering, then sometimes that's like, oh, you want to do that, great, let's have you do that. Or you actually need to do X and Y and Z and prove that you can do that first. But the only way to find that out is by volunteering and seeing if that's an appropriate thing for you to be asked to do. Now, there are definitely times where you might offer volunteer and you think you'd be very good at it, and somebody disagrees, and there is sometimes ageism and sexism involved with that. So I think it's important to kind of clarify why you might not be ready for that job yet, and make sure that it's something that people recognize you for your skills as opposed to your being just out of residency, or there's never been a woman doing that before or something like that. But you have to be careful because you don't want to be, I don't think running around kind of claiming sexism is a good way to get jobs.
I completely agree with you. It's nice to know that for all of these inspirational women and all of the achievements that they've had as clinicians and researchers and leaders, that it's all something that took time.
Mm-hmm. Yeah, actually, I think I've actually been lucky because I came into orthopedics at a time where people were looking for women to promote to get to leadership positions. So in some ways, I feel like I've been favored, if that makes any sense. I think I deserved it, but I think if you have 5 men and 1 woman that you can choose, and you're looking for diversity, then I'm more likely to get picked because I'm different. You know,
Mhm.
if you're one of those 5 men, you might be just as qualified as me. But it's like, oh, we want somebody more that's diverse. And so I think in a lot of ways I've been lucky, timing wise, to come into orthopedics at that time.
Have you faced any backlash because of that?
I don't think so. Well, I think there are probably just as many, if not more, times that I'm overlooked because I'm a woman. So I think in the end, it probably comes out about even. And there are probably times that I don't even notice it because I don't. I mean, I didn't come into orthopedics to be a president of a society or something like that. I came in it because I wanted to do surgery. Okay, so and there are some people that come into orthopedics wanting to be the president of this or a chairman or whatever, and so I think they are much more likely to kind of push hard to get to where they want to. Whereas I kind of discovered later on that I had some leadership skills. So, there might be times that I might have been passed over, not even realizing that somebody else might have, been promoted if they'd been jumping up and down more. So I think, but I think overall it's been pretty much fair. Like I said, there might be some times that I got passed over because of my youth or because of my sex, but probably just as many times I've been kind of at an advantage because of that.
That's so true. Thank you so much for sharing that. As you are a professor within the Department of Orthopedic Surgery at Stanford, I would like to hear your thoughts about resident teaching and what you think are the attributes that make a great teacher.
being able to convey information in an interesting way, and a relevant way to your, I guess, for lack of a better term, student, is really important. I mean, there's even if I just lecture at you, you'll fall asleep, or you'll try not to fall asleep, but you'll want to fall asleep because it kind of gets dull after a while. You could read a book, right? But being able to I think it's nice if you can make people think through a problem and they learn from thinking through the problem as opposed to just being told how to solve the problem. Like, how would you solve the problem? Or how would you figure out, why is this anatomy, this kind of thing. So I think engaging your student in a way that makes them more involved in the learning as opposed to just lecturing at them, I think is more effective, and they're more likely to remember more. And there's different ways to do that, obviously, but I think the more they're involved in the learning process and the gaining of that knowledge, I think it's more likely that they'll remember it in a relevant way.
Awesome. I do want to talk about the future. And you mentioned that you are a future president of the AOA. So congratulations on that. But I was hoping you could also talk about any future goals or projects that you have for yourself clinically, in research, and just with your work for other organizations.
I've actually trying to get more research dollars to our spine division to get more clinical research and hopefully lab research. There's a surprising paucity of lab space at Stanford, which I never understood until I asked my chair. I thought, this is a huge campus, but they can't build very tall, apparently, which I never thought about. So when I was at UCSF, you couldn't build that tall because you have earthquakes and stuff like that, but you could still build pretty high. And at Stanford, they can't build above a certain height. So you have a lot of like low buildings, and so that obviously it changes how much lab space you have. So I'd like to have more involvement of our spine division in the lab and getting more research out and hiring a clinician scientist that can help us do that. And so that's probably the next goal.
Awesome. Fantastic. And I know that, Dr. Hu, I know that you're very busy, and I really do appreciate you taking the time to speak with me. So I would like to go into my final 5 questions that I have for you, which I ask every guest that I have on the She Can Fix It podcast.
Okay.
What is your favorite procedure to perform and why?
So I thought a long time for this, and I actually have 2 favorite procedures, and I'll tell you why. The first favorite procedure is actually one of the most common surgeries we do in spine, which is a herniated disc. And so it's a pretty small operation, and you go in there, and this piece of disc that looks like crab meat squirts out, you grab it, and the patient wakes up and their leg pain is better. It may not be totally gone, but it's just like this very gratifying operation, and it's very common, and it is high yield from the standpoint, and most people feel better pretty quickly. So that's my first favorite operation. My other favorite operation is the other extreme, which is something called a pedicle subtraction osteotomy, where you basically take a segment of the spine out in a wedge shape. Sometimes it's a vertebral column resection, but the one we do more commonly is just a wedge out of the back of the spine. And have you done osteotomies yet?
I've done some Scoli cases with one of our new attendings here, Dr. Tuason.
Okay, yeah. So I don't know if you've seen a PSO yet.
No, not yet.
But it's basically a closing wedge osteotomy with the cauda equina in the middle of it. You basically take out the pedicles and you take a wedge out of the vertebral bodies and part of the lamina, and then sometimes they do it manually, but oftentimes with the table, and then you extend the table, and the patient gets correction of their kyphosis or more lordosis, whatever you need. And it's pretty transformative. It's also very high risk. The reason I like the other operation also is because it takes a long time to recover from a PSO, because it's usually a revision surgery. Their patients are in a lot of pain afterwards. There's a complication rate. So it takes a lot longer for them to know that they're improved. But I saw a guy today that was just so miserable before his surgery, and he's 6 weeks post-op, and he is 3 inches taller, grinning from ear to ear, just happy as a clam and doing a lot better. So kind of the 2 extremes of what I do.
Wow, that's fantastic. I think that's great that you kind of I support the 2 favorites idea. I think that's fantastic. What are your go-to topics for grand rounds presentations?
My kind of current go-to topic, because it kind of evolves with time, is what I call the spine bone is connected to the hip bone, and it's about sagittal balance. Do you know about that yet?
Yes.
Yes. So it's kind of my talk that talks about how why I first realized how important it was the patients that I fused, that their x-rays look great, but in retrospect I flexed them, I fused them flat, and they did okay, but then later on had problems, and then when I did their PSO or corrected them, they were just doing a lot better. So I show a lot of examples of that, and kind of the evolution of how we kind of came to the understanding of sagittal balance. And I throw in some hip stuff for the non-spine surgeons, and that's kind of so it gets people thinking and talking, and it's kind of fun.
Oh, getting everybody involved. That's awesome.
Exactly.
What is your favorite story/memory as an orthopedic surgeon?
That was a hard one. I mean, there are just so many things. I mean, they're just this patient today that was so miserable before the surgery. He cried when I first told him I would do surgery on him because people had kind of ignored him, for ages, and told him there was nothing that could be done. So everything from just having a patient that you're able to help a lot when they've given up, to the times where very you'll like this one. So the times when I have to I have to cut a rod for a scoliosis case, and what's sometimes funny, and the residents laugh at me. I'll ask the medical student to cut it, and they'll have a hard time cutting the rod. And then my favorite thing to do is to say, "Do you want me to help you with that?"
Oh my word.
The medical student looks at me because they're usually twice my size. And but the residents all figured out I was going to do this, so they started telling the medical students that I was going to do this. But it's kind of fun to do that. So,
that's fantastic. Oh my gosh. My next question for you are: what are your favorite activities outside of the operating room and outside of medicine?
I like to do a lot of sports. I'm a lousy skier, but I like to ski. I'm a lousy golfer, and I like to play golf. I'm a very slow biker, runner, swimmer, but I like to do all those things. I like to read. I've got 2 kids and a husband who are great. My kids are both at school, but when they come home from school, it's always fun to hang out with them. So those are probably the main things.
Oh, that's awesome. My last question for you, Dr. Hu, is what advice do you have for orthopedic surgeons and orthopedic surgeons in training?
I think it's a great profession that we're in. We get to really change the quality of life of our patients. I think we really have to be responsible because patients trust us with that, and I think giving them a realistic expectations and being honest with them about expectations and goals. I mean, especially that's particularly important in spine surgery, but I think it's important in everything we do. And I think as long as we keep the best the patient in mind as our kind of guiding goal as far as what we're there for, I think we'll just do the right thing. But it's really important to keep that in mind, and I think we're really lucky to do what we get to do as part of our jobs. Basically, it's really fortunate we get to do this.
Ugh, that's amazing. Thank you so much, Dr. Hu. I really do appreciate you taking the time to speak with me today, and I am just so excited for everything that you're going to achieve in the future. So thank you so much. Thank you so much for joining us on this episode of the She Can Fix It podcast with Dr. Serena Hu. Please subscribe to our podcast to show your support. We are on Twitter and Instagram at She Can Fix It Pod. I want to take this time to thank my editor and co-producer, Andrea Venny-Kirk, without whom this podcast would not be possible. Thank you so much for listening.